Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm so happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of Divine Mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to offer you a summary of a presentation given by Dr. John Howland titled Medicine, Suicide, and Human Freedom, Physician-Assisted Suicide. Dr. Howland, a family physician, discusses key topics of our contemporary society that deal more and more frequently with euthanasia, with physician-assisted suicide, and human freedom. In 1994, voters approved the Death with Dignity Act, and physician-assisted suicide was legalized in Oregon. It was legalized in Washington State in 2008. In this talk, Dr. Howland gives 3 examples of people with serious illness. One had incurable esophageal cancer. His children stepped up and helped care for him. He and his children reconciled, as did the patient with God, before his death. Another woman with breast cancer wanted a lethal dose to end her life. The doctor diagnosed depression and ordered medication, but she never filled the prescription. She saw another doctor who prescribed her a lethal dose of Seconal. A third young lady, diagnosed with depression, ended her life. She committed suicide. There were over 300 people at her funeral, and many were affected by her death. The long-term effects of her suicide were many. All 3 died with different modes and different family effects. In this country, suicide is the 10th leading cause of death, and the highest rate of suicide is in the 45 to 54-year-old group. Physician-assisted suicide differs from euthanasia in that in the latter, the physician is more an active participant and more involved in the process. The Netherlands legalized euthanasia in 2001. In 2011, there were 114 prescriptions for lethal doses written. There were 71 deaths as a result, as the rest changed their minds. Amazingly, only 1 of the 71 that died had been referred for psychiatric evaluation. Suicide in Massachusetts among high school students is a big problem. 7% of students had attempted suicide, 13% had seriously considered it at some point, and 11% had made a plan on how to carry out the act. People argue that suicide is a right and one has the freedom to do so. The Church teaches that it is contrary to natural law and society, and this is found in the Catechism of the Catholic Church, Articles 2281 and 2282. The U.S. Supreme Court ruled in 1997 there is no right to commit suicide. Those who are against suicide consider it a tragedy and not a choice. Thus, preventing suicides is an act of compassion. Assisting in suicide is not. The physician must prescribe a safe prescription and never a lethal one. And Scripture tells us, then when in doubt, choose life. I invite you to listen to the full presentation by Dr. Howland as it covers topics of great importance: medicine, suicide, physician-assisted suicide, and human freedom. Thank you.
This morning, I'm going to be talking about a difficult subject. We're going to be hearing some wonderful good news later today from the sisters, news of great joy. My subject this morning is about a painful subject, and that is the subject of suicide. There are a number of reasons why this topic is important to discuss, but it's extremely timely here in the state of Massachusetts. As many of you may know, a group has put forward a law to be voted on this November as a ballot initiative, which would legalize physician-assisted suicide in the state of Massachusetts. Assisted suicide was legalized in Oregon in 1994 and in Washington State 4 years ago. What I'd like to do this morning is to put the subject of assisted suicide in its proper context, and that is the context of suicide in general. There's a number of aspects of assisted suicide that I won't be covering. Focus is, again, assisted suicide in relationship to suicide. I want to start out with the story of a patient of mine. I do palliative care, hospice care as part of my practice. I'm going to call him Joe. He was a somewhat crotchety gentleman who lived alone, developed cancer of the esophagus. He became quite ill, was admitted to the hospital, felt terribly hopeless, despondent. He felt himself to be a burden. He lived alone, had no one really to care for him, was somewhat alienated from his family. This was the sort of person that the proponents of assisted suicide would suggest is the perfect candidate. His rallied to his side during his hospital stay, and during that time some wonderful things happened. They took him home and cared for him at home with hospice. He died with his family present. And during those last days, he reconciled with his son. And his sons and daughters, who had been somewhat on the outs with each other, came together. During the time of his illness, he agreed to have a priest come and see him, and he was reconciled to the church. He had been separated from the church and from his faith for many years. But before his death, he was able to reconcile himself to God. This is another story. This was not a patient of mine, but a woman living in Oregon who was suffering from metastatic breast cancer. A number of years ago, she went to her doctor and asked for a prescription to end her life. Her physician diagnosed her with depression and gave her a prescription for antidepressants, but she never got it filled. A family member then helped her to find another physician who would write her a prescription for medicine to kill herself. The lethal dose was prescribed, and she died in 1998. She was the first person in the United States to die of assisted suicide. I'm going to tell you a third story, and this was another patient of mine, and I'll call her Annie. She was a very sad young girl who grew up in a very difficult family situation. Her father was incarcerated. Her mother was mentally ill. Annie lived with her mother for a while, then with her grandfather. Then she was bounced around through the foster care system and had trouble in school. And one day, feeling very much alone, a sense of hopelessness, she took her own life. Her grandfather had previously attempted suicide himself, and in a sense, she followed his example. She hung herself in the family home. Over 300 people attended the calling hours at the funeral home. I remember standing in that line with all those young people at her funeral. There are a couple of lessons that I took from these three stories. One was Joe, who died a natural death. He died at peace with himself, with his family, and with God. Barbara sadly died of suicide. She died depressed and feeling herself a burden. Annie also died of suicide, also feeling hopeless and thinking that suicide was a solution. This is a well-known painting by the French Impressionist Manet. Perhaps all of you here, like me, have been affected in some way by someone who has taken their own life, perhaps a family member, a friend. This is a subject which touches all of us. When I think about this subject, I think of patients and others who have died in my own life. Literally, suicide means killer of oneself, coming from the Latin suicida. Assisted suicide is where a physician helps a patient voluntarily bring about his or her own death. The proposed law in Massachusetts would legalize assisted suicide. It would be restricted to patients thought to have a terminal illness with 6 months or less to live. Most of those who promote assisted suicide like to avoid using that term. They prefer the terms aid in dying, death with dignity, or choice in dying. But it's painfully obvious that assisted suicide is suicide. The common mechanism for death from assisted suicide is a prescription for Seconal, also known as secobarbital. It's a barbiturate, which used to be used for sleep. Most often, something on the order of 100 capsules are prescribed, which amounts to about 10 grams. That's a huge handful of capsules, which are then taken all at once. It's important to understand the difference between PAS and euthanasia. In the case of assisted suicide, the physician assists the individual to commit suicide. In the case of euthanasia, a physician or other person actively takes the life of the person. In the case of euthanasia in the Netherlands, for example, injections of medication are given to cause death. To think about it conceptually, assisted suicide is subsumed within the greater topic of suicide, and euthanasia within the greater subject of murder. Brief summary of some of the history. Going back to 1980, Derek Humphrey formed what he called the Hemlock Society. Ironically, Pope John Paul issued his declaration on euthanasia that same year. In the 1990s, Dr. Kevorkian began his reign of terror, developing what he called a suicide machine. In 1991, Washington State voters attempted to legalize assisted suicide, but that effort was fought back. In 1992, Humphrey published his book, Final Exit. Many of you perhaps have heard or seen that book promoting suicide. And then in 1994, Oregon became the first jurisdiction in the world to legalize the practice. In 1998 and 2000, similar measures were defeated in Michigan and Maine. In 2001, the Netherlands became the first country in the world to legalize euthanasia. It had been practiced there for many years before. And in 2008, Washington State approved assisted suicide. There are 2 states which now have legalized the practice. And in 2012, the so-called Death with Dignity Act is being proposed to Massachusetts voters. Some of you here are perhaps not from Massachusetts, but I assure you, if assisted suicide is successful here, it will be at your door soon. There are a number of countries around the world where assisted suicide has been legalized: Colombia, Germany, Luxembourg, the Netherlands, and Switzerland. In the case of Switzerland, a very bizarre and tragic situation has developed, which is referred to as suicide tourism. An organization called Dignitas was established, and some 800 or more people have traveled to Switzerland to take their own lives. If you're interested, the charge is $5,286. Suicide is something about which there is a stigma. It is viewed negatively in general by society. Eileen McNamara said something I thought that was very poignant. Suicide remains the sorrow that still struggles to speak its name. We use language for suicide which is particular and different from what we would use for death from other causes. We say that someone committed suicide, whereas we would say someone died of cancer or died of heart disease. We also would say someone committed murder. The stigma of suicide not only is prominent in society, but also affects those loved ones who have lost someone by suicide. It's often something which people hesitate to discuss. In Scripture, there are a number of incidents of suicide. In the Old Testament, King Saul fell upon his own sword to kill himself. His armor bearer was the first recorded case of so-called copycat suicide. In the book of Tobit, Sarah had good reason to consider suicide, but decided not to. In the New Testament, the most famous incident of suicide was Judas Iscariot. St. Paul, when he was freed from prison by a miraculous event, prevented his jailer from attempting to take his life. The book of Job, although it doesn't discuss suicide directly, is certainly very relevant to the topic. Job was a man who, if anyone could justify his own taking his life, he was one. This was what his wife said to him: "Curse God and die." But Job replied somewhat later, he said, "I know that my Redeemer liveth." Job had hope, even though his circumstances were desperate. Suicide around the world accounts for some 1 million deaths. The rate per 100,000 is 16 worldwide. The country with the highest suicide rate is Lithuania. The U.S. is down at number 41 with a rate of 11.8. Amongst American states, Montana has the dubious distinction of being the state with the highest rate. States where assisted suicide is legal have quite high rates as well. One should note here that these do not include the assisted suicides. Massachusetts, we're actually doing very well. We're number 48, and so we have some reason to pat ourselves on the back. The District of Columbia has the lowest rate. This is probably a result of the fact that in Washington there's a very high percentage of African Americans who are very resistant to the idea of suicide. Suicide is the 10th leading cause of death, but only 1% of deaths are by suicide, thankfully. They outnumber homicide 2 to 1. In the U.S., about every 14 minutes someone dies of suicide. About 1 million attempts at suicide per year occur in the U.S. Men are much more likely to commit suicide, but women are more likely to attempt it. In Oregon, there's some data I want to show about assisted suicide. Since the practice began in 1998 with the patient that I described at the beginning, Barbara, there have been almost 600 deaths recorded. For last year, the number of suicide prescriptions written were 114. Not everyone who is given a prescription decides to take their life, but 71 persons killed themselves in Oregon in this way last year. Of those 71, this statistic is staggering. Only one is known to have been referred for psychiatric evaluation. Common reasons for requesting assisted suicide: loss of ability to engage in activities making life enjoyable, loss of autonomy, loss of dignity, inadequate pain control was only a factor for a third of patients. If we look at how people take their lives, there's a significant difference between men and women. For both groups, firearms is the #1 cause of suicide, but it is the predominant form amongst men. Hanging is about equal. Poisoning or overdose is much more common amongst women, and other causes are less often. This is some Massachusetts data from 2009. There were 539 suicides in our state that year. For self-inflicted injuries, almost 5,000 were admitted to the hospital that year, and there were some 6,000 self-inflicted injuries causing people to go to the emergency room. In Massachusetts, and this is similar nationwide, the suicide rate is almost double that amongst whites as it is amongst blacks, Latinos, and Asians. It used to be that the age group that was most likely to commit suicide was the elderly male. That has changed, and now it is the baby boomer, the 45 to 54-year-old. Thankfully, I am just out of that range now. I'm going to move quickly through some of these, and I do have some copies of my notes if anyone is interested. Amongst high school students, there was a survey done, and a staggering almost 7% of high school students in 2009 had attempted suicide. The rate of suicide over the last 16, 17 years has trended down. It reached a nadir in 2000 and then has steadily climbed, and the climb has been quite significant. Of note is the fact that assisted suicide began to take place in Oregon here, and there is a clear association between the legalization of assisted suicide and the rise of its practice. Suicide is an increasing problem nationwide. The suicide rate has increased some 14% over the last 9 years. The rate grew quite rapidly amongst the boomers, 28%. In the state of Oregon, since the year 2000, the suicide rate has also been rising and now is 52% above the national average. In Massachusetts, we've also seen a rise, and it's risen faster than the national average. We're up 28%. The Samaritans, which is the major organization in Massachusetts that receives suicide calls, has seen a marked jump in their call volume. One concept that's important to understand about suicide is that, like an infectious disease, it is contagious. Suicide of a family member increases your risk of suicide. The young girl Annie, the patient of mine that died, her grandfather had attempted suicide. The odds ratio, if you have a family member who has committed suicide, increases by 2.5. Suicide, as I mentioned earlier, leads to copycats and what are called clusters. There's a famous example of Marilyn Monroe. Within the year or so after her death by suicide, some 200 people took their lives. As a result of the problem of copycat suicides, there's been a real effort by the media to be very careful about how they publicize suicide events. They have developed specific guidelines not to romanticize a suicide, not to portray it as heroic, never to say that suicide relieved pain or suffering. And that's a very interesting statement. You would think that that would be something they would want to say. But the reason is because suicide actually causes tremendous pain for the survivors. Those who propagandize for assisted suicide do the opposite of the media guidelines. When Derek Humphrey's book was published in 1992, Final Exit, he described a very specific method of suicide, and within a year or two, there were cases of those types of suicides occurring around the country. There was a study published in the New England Journal which looked at New York City data and found that at least 15 suicides could be directly connected to Final Exit. The book was present where the body was found, that sort of thing. I'm going to move through this slide. The case of Kurt Cobain is quite instructive and points out the fact that if after a suicide has occurred, people make a real effort to say, this was wrong. What this person did should not have happened. That's an important thing to say. So if you're ever in a situation where a suicide occurs, it's very important to spread that message. Why do people kill themselves? Most people actually think of suicide at some time in their lives. My guess would be that most of you here, at some point in your life, that thought has crossed your mind. I know it has me. 90% of people have a psychiatric illness at the time of their suicide, but most people with mental illness don't ever commit suicide. Those who die by suicide actually work up to it. It's not usually a sudden, unexpected event. The desire to commit suicide must be linked up with the ability to do so, and I'll talk more about what that means. There are three components to why people commit suicide: lethality, loneliness, and burden. This way of conceptualizing the subject is from very excellent work by psychiatrist Tom Joyner, which I would encourage anyone interested to look at. Lethality is the first significant component, and as Joyner describes it, the acquired capacity for lethal self-injury. People who commit suicide usually have attempted suicide. They have learned by their mistakes. They get better at it until they are finally successful, if you will. Exposure to violence during childhood, physical violence, sexual violence, especially sexual violence, increases the risk for suicide by giving the person that capacity for self-injury. The poet Robert Lowell, who himself suffered from manic depressive illness, said something very interesting. He said, if there were some little switch in the arm which one could press in order to die immediately and without pain, then everyone would sooner or later undertake suicide. There's a lot of truth in that. In fact, physician-assisted suicide is that little switch in some way. The second component is loneliness. Joyner describes it as thwarted belongingness. It's really true that as long as we have a sense of belonging to family, to church, to society, we're very unlikely to take our lives. There was a tragic case of a man who took his life. He jumped from the Golden Gate Bridge. He left a suicide note in his room which said, I'm going to walk to the bridge. If one person smiles at me on the way, I will not jump. Burden is the third component. Joyner describes it as a deep sense of incompetence or ineffectiveness, a low quality of life, if you will. Burden is more a matter of perception than actual facts, however. In terminal cancer patients, those who actually commit suicide, the key factor is this sense of being a burden on others. And fear of being a burden is a major factor causing many to seek assisted suicide. Amongst the terminally ill, those who desire death have been studied, and clinical depressive illness or a sense of hopelessness is generally found. Although it is difficult to distinguish the situation regarding a person's terminal illness from depressive illness, it is clearly present. Suicide obviously is not a solution for depression. Judas Iscariot committed suicide. Why? He had acquired the capacity to murder, betraying his Lord. He had been cast out by his fellow disciples. Filled with remorse and guilt, he no doubt felt himself a burden. Once one has acquired the desire for suicide, the trigger for that event is described as a suicide crisis. It's a time-limited occurrence that causes us to act upon our desires. There's often a trigger, an event that precipitates it. It's associated with an intense emotional state. People who are actively suicidal are very agitated, very angry, very distraught. There are changes in behavior that are seen, suicide notes, quitting one's job, not paying bills, various things like that. There's evidence of deterioration of functioning, increased substance abuse, etc. Often, however, a change of heart can occur if you can just help the person get through that crisis. There was another man who attempted suicide by jumping off the Golden Gate Bridge and survived. Afterwards, he said, "I instantly realized that everything in my life that I thought was unfixable was totally fixable, except for having jumped." There was another survivor of jumping off the Golden Gate Bridge who said, after he realized that he had survived, "What the hell did I just do?" A lot of people who argue that suicide is sometimes a good thing argue on the basis of autonomy, or what one might call choice. During the panel discussion, we're going to be talking about autonomy. And it's important to emphasize that autonomy can't be separated from truth or from the sovereignty of God. Human autonomy has to function within the moral order. Choice and autonomy are not autonomous. Freedom is also something that is related to the situation of suicide, and some would say we're all free to commit suicide. In some sense that's true, but I would argue that we are not free to do so, in the same sense that I can rob a bank, but I am not free to do so. There are a number of reasons why suicide should be considered the wrong choice. It's contrary to natural law. All of us have a most powerful instinct for survival. Just try to stop breathing for a minute or so and you'll quickly realize that. Suicide is contrary to the good of society. It deprives society of a member of the social fabric. Talk to a family member of someone who's committed suicide, and that becomes obvious. As a physician, suicide is contrary to the Hippocratic Oath, which states in part, "I will neither give a deadly drug to anyone who asks, nor will I make a suggestion to this effect." And suicide is contrary to stewardship, as the Catechism teaches us, we are stewards, not owners of the life God has entrusted to us. When I see patients who are feeling hopeless or depressed, perhaps at the end of their life, I often tell them, "You're still alive. God must not be done with you yet." Suicide is also contrary to love. It is contrary to the love of God, to the love of self, to the love of neighbor. Its damaging effects ripple outward. This was an interesting statement about the effect of suicide on loved ones. It's the precipitant of the worst kind of bereavement experience and the most disturbed mourning, placing survivors at risk for physical and mental health problems greater than that for individuals bereaved due to other causes of death. Assisted suicide is also a poor choice. As our catechism teaches us, an act or omission which of itself or by intention causes death in order to eliminate suffering constitutes a murder gravely contrary to the dignity of the human person and to the respect due to the living God, his Creator. And voluntary cooperation in suicide is contrary to the moral law. So if I, as a physician, write a prescription, perhaps out of a misguided sense of compassion to a patient, I am cooperating in suicide, and this is an immoral act. As Catholic physicians, we seek to follow the ethical and religious directives of the Church in this country, and there's a very specific statement regarding this subject, that Catholic healthcare institutions may never condone or participate in euthanasia or assisted suicide. While there are many acts of varying moral gravity, a number of them are pressing concerns, and amongst those are assisted suicide. Fortunately, in life, there are things other than suicide. I'm going to move through this section here in the interests of time. I don't want to skip over this one too quickly. Let's talk a little bit about suicide prevention. The keys to suicide prevention are, first of all, access to services. If patients or people who are at acute risk of suicide have no one to go to for help, they're in big trouble. Treatment is critical. Treatment for mental illness, which often is a precipitant for suicide, for substance abuse, for other conditions that may lead to suicide. The key to intervening in someone who is acutely suicidal is to reduce that sense of burdensomeness, to reduce that sense of not belonging. By doing that, one can help change the heart. Education is also key. Public and professional education is very important to raise awareness about suicide. In Massachusetts, we have a state organization to help promote suicide prevention awareness. And as I mentioned earlier, guidelines for the media so that they are very careful about how they report on this subject to not in any way make it sound like a good thing. One other key aspect to suicide prevention is the practice of involuntary commitment. In Massachusetts, this is known as Section 12 of the state law, and it authorizes a physician, mental health professional, or police officer to restrain and hospitalize an acutely suicidal person for 3 days. Subsequently, if they continue to be suicidal, by court order, they can remain hospitalized. The process of involuntary commitment is, historically speaking, relatively new. and originated in the 19th century. It became misused and overused, but now one could argue the pendulum has swung perhaps too far in the other direction, and its use is very much restricted. In the case of involuntary commitment, autonomy is set aside in order to save a life. It's a very important concept. It's also an extraordinary act for society to take away someone's autonomy in order to save their life. There are very few other things that societies do which entail such extraordinary power. The only others I could think of would be the power to arrest a suspected criminal or powers during wartime. With assisted suicide, we have a problem because in the case of assisted suicide, people argue that we have a right to commit suicide. And this question actually went to the Supreme Court in 1997, and the court ruled unanimously that there is no right, according to our Constitution, to commit suicide. One of the comments in the majority opinion from Justice Stevens was very interesting. He said, "The value to others of a person's life is too precious to allow the individual to claim a constitutional entitlement to complete autonomy in making a decision to end that life." The efforts to legalize assisted suicide have significant impact upon the wider effort to prevent suicide. As suicide rates rise, many collateral deaths occur, copycat suicide clusters. The rationale for suicide prevention is undercut by efforts to justify assisted suicide. Assisted suicide glorifies and removes the stigma from the act. Suicide needs to be stigmatized. It needs to be seen by all of us in a negative light. Suggesting that suicide is a solution for suffering encourages more to see suicide as a way out of their problems. People who are not terminal, people like young Annie who hung herself. To sort of sum up a comparison between the issue of preventing suicide versus the concept of assisting suicide, we can see clearly that suicide is a tragedy. Those who support assisted suicide would argue it's a choice. I would say preventing suicide is an act of compassion. The person arguing for assisted suicide would say, "Oh, but suicide is compassionate." I would argue suicide must be prevented. My contraire would argue, "Oh, it's a choice." We have suicide prevention hotlines. I can see someday an aid in dying hotline. We have an organization called the Samaritans. On the other side is what is known as the Hemlock Society, or currently their name is Compassion and Choices, a very ironic title. As a physician, I'm always conscious of the need to prescribe medication carefully, especially to patients who are at risk of suicide. I am very careful not to write for a large number of pills that could be taken in overdose. If I were a physician prescribing for assisted suicide, I would want to make sure that the dose were lethal. As a physician, I try to see myself as a healer. Assisted suicide casts the physician in a quite different role. Preventing suicide is truly about life. I would argue assisted suicide is about death. For those of you who might want further information about the efforts to fight doctor-prescribed suicide or assisted suicide, check out this website. This is an organization here in Massachusetts which is seeking to oppose the ballot initiative for suicide. These were some flowers that my wife and I saw on one of our vacations, and I'd like to end with that note. Thank you very much.